Today, we'll be diving into a topic that sits at the intersection of prevention, innovation, and access, and that topic is HPV screening. Human papillomavirus, or HPV, is the most common sexually transmitted infection worldwide and the primary cause of cervical cancer, as well as a contributor to other anogenital and oropharyngeal cancers. The good news, though, is that we have tools to both prevent most of these cancers through vaccination and effective screening. And when it comes to screening, for decades, it's relied on clinician-collected cervical samples, initially tested using just cytology, and now increasingly tested for high-risk HPV genotypes using various molecular approaches. But the landscape is once again changing. Advances in diagnostics are expanding how, where, and by whom samples can be collected. Self-collected vaginal swabs and even urine-based HPV testing is emerging or are emerging as powerful strategies to reduce barriers, increase participation, and reach individuals who might otherwise remain unscreened. Welcome to Editors in Conversation. I'm your co-host, JCM editor Ellie Theel, and am joined by our other co-host as well as JCM editor-in-chief, Romney Humphries. Romney, good to see you again.
Good to see you, Ellie.
So, we're talking about HPV. Have you guys started offering any sort of alternative HPV screening using self-collection methods at Vandy as of yet?
Yeah, it's the hot topic, isn't it?
Yes, it is.
Yeah, we are working through this. I think that we have started offering the option of HPV only, which was a big step for us at UMC. And we're kind of struggling a little through how to best validate the self-collect samples. How about you, Ellie?
Yeah, we went live with in-clinic self-collection of vaginal brush samples, but it took us a good 2 years to fully validate and implement. So it's definitely a commitment.
Yeah, no doubt, but important and good for our patients. So
absolutely. So this episode is brought to you by the Journal of Clinical Microbiology, which is available at jcm.asm.org. And as always, we ask that you subscribe to this podcast and rate or review it. Editors in Conversation is supported by the American Society for Microbiology, which publishes JCM. And if you're a member of ASM, you can get up to 50% off publication fees when you publish in JCM or any of the ASM journals. So moving on to the fun stuff, today with us to talk about all things HPV are two new to the podcast guests. We have with us Dr. Sharmila Maneshwar. Hopefully I got that right, Sharmila.
You did.
Who is the Director of Research and Development at Phase Scientific Americas in Irvine, California. Welcome. Really happy to have you on today.
Thank you very much for the invitation to speak on this podcast. It's a first for me, and it's an honor to be here.
Of course. Happy to have you. And then we're also joined by Dr. Jeff Klausner joining us as well. Dr. Klausner is a professor of medicine, population and public health sciences at the University of Southern California Keck School of Medicine. Jeff, great to have you on as well.
Yes, very pleased to be here with you. And, for me, it's a really important topic. How can we increase cervical cancer prevention? So I'm glad we've highlighted this as a priority and having a conversation.
Yeah. And Jeff, if I can't, this has been a long time passion of yours, right? Increasing access and surveillance. I remember when we both worked at UCLA, Jeff and I, some years ago, and hepatitis C screening was the big topic. So.
Yeah, absolutely. I mean, I really think there's, ways to go with our diagnostics. A little bit frustrating here. It takes 2 years to bring on and validate a new diagnostic, but that's the way it is. And, we'll keep developing and pushing new diagnostics out there.
Yeah. I will say it was mostly IT. IT is always the bottleneck, right? So we are excited to talk to both of you about your recent JCM publication. For the listeners, it's entitled Performance of a Novel Urine-based Test for Detection of Cervical Human Papillomavirus Infection. So we're just going to dive right in. And we'll start with you, Sharmila. So can you talk to us briefly about where we stand with HPV cases, kind of as a background, given the availability of vaccines, and then how are we doing with screening rates?
Sure. So I think as of 2026, the American Cancer Society estimates that there will be at least over 13,000 new cases of invasive cervical cancer, and approximately 4,200 women may die of it. Vaccination has shown great promise, and in countries where there's high uptake and where it is paired with regular HPV screening, such as Australia and the Netherlands, we already see meaningful declines in cervical cancer, and even in high-grade precancerous lesions. In the United States, however, vaccination coverage has not yet reached the same levels that are needed to achieve this kind of population level impact. According to the CDC report from 2024, the vaccination rates have stalled for a second year in a row in 2023. About 61% of teens are up to date. That is, they're fully vaccinated for HPV, but a higher number have at least, about 77% have at least had one dose. And even though the cervical cancer, the cases of cervical cancer have dropped since the 1970s due to these screening programs, the decline has stalled in recent years. So as a result, I believe screening really continues to need to be and play a critical role, particularly for older women who did not have or were not eligible for screening when they were younger. Unfortunately, the screening participation remains lower than desired, and I know that's a major objective of the Healthy People 2030, but I believe that there are still ways to go, and there's still a big gap.
Yeah. So can you remind us what the current HPV screening recommendations are? And then talk a little bit more about what you see as some of the barriers to women, to getting to that high level of screening that we hope to see of at-risk women.
Sure. So, there's a lot of independent societies that have put in some of their own guidelines for screening programs, and a great effort has been made to come up with the enduring consensus guidelines framework to reduce the confusion and among the differing recommendations made by independent groups such as the ACOG, ASCCP, ACS, and the USPSTF. So by working collaboratively, there is now, it has been made easier for practitioners to deliver consistent evidence-based care. From the most recent guidelines, HPV testing as a primary screening option as a method for women 30 to 65 is already implemented. So for average risk women starting at the age of from 21 to 29, a pap smear is still the most recommended option. And for all women 30 to 65, a primary HPV testing has been implemented for every 5 years, or co-test every 5 years as well. The American Cancer Society has taken a bit of a more progressive stance and also recommends HPV as a primary testing option beginning at the age of 25.
Mm-hmm.
Some of the barriers. Yeah, go ahead.
Getting a consensus, like a single guideline, will be so helpful.
Right.
because I remember trying to learn it during, fellowship and just being confused.
Right.
How can there be so many different recommendations? So, we all look forward to that.
So, unfortunately, there are still several barriers to screening participation, cultural and personal barriers, because it does require, at the current time, still requires cervical specimen, clinician-collected cervical specimens. Another barrier is limited healthcare resources, access to OBGYNs, to keep up with patient needs, especially in rural areas. Medical insurance status remain some important factors. Obvious, but I think still important that this not only affects the uninsured, but affects affects a significant portion of the insured population as well, where women are balancing careers and families and other responsibilities and struggle to prioritize their own preventive health care. I think those are some of the barriers that we've seen.
Yeah, definitely. And Jeff, maybe I'll have you chime in here too, because I know you're pretty close to patients and patient care. And so from your lens, what do you see as the primary barriers for people? Like, why aren't they going in and getting screened?
Yeah, I think, combination of they don't know these recommendations. And I think partly, the confusion and the multiple recommendations kind of cause people to have uncertainty, right? So we see that with the current challenges with vaccine recommendations. Every time there's different groups saying different things, people are hesitant and pause. And then, secondly, access, right? We know that many counties in the United States do not have a gynecologist, do not have access to women's health care. We've tried to, supplement by having more federally qualified health centers, women's health centers, nonprofit health centers, but those are overwhelmed often with long waits for care. And it's just difficult for people to go in, find the time to get these necessary tests.
Yeah, definitely. I can sympathize with that.
Yes.
I'm not sure when I last had some preventative care myself. Anyway, probably TMI. So, Sharmila, what kind of options have people developed to kind of overcome these barriers? I mean, getting into the office is a barrier, but like what else?
So I think recent FDA approvals of self-sampling it will hopefully improve that the participation significantly, specifically self-collected vaginal swabs, where women can collect the self-collect the sample even at home and mail it into the lab to be tested. However, one of the barriers still is if you are positive, you still have to go into the doctor to see, to get a pap smear. However, but at least the initial testing can be done at home. Some women may still perceive that as invasive or uncomfortable. So I think, other options such as urine may help alleviate that barrier.
Yeah, definitely. So Jeff, you guys looked at urine. Obviously, that's an easier sample to get than even a self-collected swab. So tell us a bit about the idea behind using urine as a source and what kind of benefits and maybe even challenges that might be associated with that approach.
Sure. Well, the benefits lie in addressing many of the barriers we've already discussed. Urine can be collected in a wide range of settings, is completely non-invasive, is very familiar to both patients and healthcare professionals who've used urine, for a century or more for diagnostic testing, for screening for sexually transmitted infections, pregnancy testing, drug screening, diabetes test, kidney function test. So everyone is very familiar with urine as a specimen. Urine also is a great specimen in what I call congregate settings or detention facilities or military populations or other group settings where it's just not necessarily that practical to conduct a one-on-one type of visit. And, we're kind of riding, there's some wind in our sails, if you will, now that the guidelines for self-sampling are emerging and there's reimbursement for standalone HPV, testing. An HPV urine test is both scientifically and, from a business case, feasible. And, I think, seeing those opportunities, both to increase access, and as a business case, that's what kind of converges to make new diagnostics reality.
Yeah, absolutely.
So, Sharmila, urine is not necessarily a new specimen type for HPV testing, but the assay you guys designed using urine has some unique features to it. So, can you tell us about what those are?
Sure. Well, traditional methods for nucleic acid extractions from liquid samples, such as urine, typically use solid phase for capture of nucleic acids, column-based technologies. The limitations with some of those is how much input volume you can put into the extraction. So with our proprietary Phasify technology, we've overcome that, and we're able to start with a much higher volume, such as 40 ml, to really enable low abundance nucleic acids to be fully extracted. And you don't have to do multiple extractions and things like that. So this method is based on the aqueous two-phase systems that can be used to efficiently partition macromolecules of interest, in this case DNA, and both cell-free and cellular DNA, from a large volume without having to bind it to a solid surface. So you're partitioning it from a higher volume to a much smaller volume, so that also achieves the function of concentrating the nucleic acids out of that large volume of input sample. So the DNA is then purified further on actually a column-based method. So essentially, we are going from 40 ml of urine to 60 microliters of DNA to achieve that really good concentration and detection sensitivity. So the downstream test is standard PCR-based technology on a real-time PCR platform. And the test provides differentiated results for HPV 16 and 18 and grouped results for the other 12 high-risk subtypes.
Yeah. So really kind of the nifty part, if you will, is using a high volume of urine, kind of concentrating it down to a workable volume, right. which is key when you think about, dilution effects, and you guys get into that in your paper. Mm-hmm. So just Jeff, to evaluate the assay on urine, you basically undertook a clinical study of sorts. Can you share with us kind of the overview of the design? So, what patient population did you target, collection requirements? What did you guys ultimately compare to as your reference standard method, and so on? Just kind of a general overview of the study design.
Sure. Well, the purpose of the study was to generate the performance data required under CLIA or CAP validation framework for clinical labs to perform real-world patient testing. Right. So when there's, new diagnostics, you can call them laboratory developed tests, that there needs to be a study to generate data to comply with the CLIA requirements. So although clinical specimens were used, it's important to distinguish this type of work from an FDA level study intended to determine the clinical validity and suitability for cervical cancer screening. So in the screening context, analytic sensitivity must be balanced against clinical outcomes to assure appropriate management to avoid unnecessary over or under referral. In our study, there were 128 women between the ages of 19 and 17 and 77, between the ages of 19 and 77 years, enrolled between May and August 2024 at 4 sites in Santa Fe, New Mexico, Albuquerque, El Paso, Texas, and Salt Lake City. Those sites were chosen because of the higher number of unvaccinated participants and higher prevalence of HPV in that study population, but where participants were not pre-screened for HPV positivity. Median age was 36 years. About 2/3 were white, Hispanic, or Latino, and about 23% or so were white, non-Hispanic, or Latino. At enrollment, participants provided a physician-collected cervical specimen collected in BD SurePath and a patient self-collected first void urine specimen in the specific phase urine collection kit, where for first void means that the participant had not passed urine for at least 2 hours. Menstruating women were excluded. And then basically the urine test, as previously described, in terms of the use of Phasify technology, were compared with the Roche Cobas HPV test, where an independent lab processed and tested. And then the outcome of the study compared the findings from both those tests.
Quick question. You enrolled pretty young participants, less than 25 years. Can you quickly talk about the reasoning for that? Is that just to get additional?
Yeah, so the median age of participants was 36 years, but women as young as 19 were enrolled. So there were not a lot of women enrolled between 19 and 25, but we did enroll under 25 to accelerate completion of enrollment in the study.
Great, cool. So Sharmila, let's dive into the results. Maybe you can take us through what you found from an accuracy perspective in your clinical and contrived samples.
Sure. So as part of the CLIA and CAP level validation that we did in the lab, as Dr. Klausner alluded to, we, in addition to the clinical specimens that were collected, we also did some spike-ins into negative urine. And we spiked in the 14 high-risk subtypes. These are generally plasmid DNAs, spiked in at 3 to 4 levels into 40 ml urine. Also compare, we also had the 128 clinical specimens, both HPV positive and negative. So for the accuracy, we looked at the spike-ins accuracy, and we were able to show that it had a 96.8% accuracy. There were a couple of specimens that did fail for just empirical reasons. And then the overall percent agreement for the clinical specimens with the reference Cobas test was 82.3%. We did look at the non-concordant samples in this case and subjected them to an independent HPV NGS test. And the results of the adjudication showed that the adjusted overall percent agreement was 93%, suggesting our test does pick up some of the positive samples that the reference test did not.
Yeah, definitely. So along those lines, so I think there were a total of 12 samples, right, that were positive for HPV by your NGS assay. So what do you think is going on there? Any thoughts on why those were detected in urine but not by the current standard of care?
Sure. So, I mean, the Roche Cobas HPV assay is extensively validated and well studied test. It's widely recognized for achieving a clinically appropriate balance of sensitivity and specificity. We believe that Phase's ability to, efficiently capture both cell-free and cellular DNA from large input volumes has the potential to analyze analytical sensitivity in downstream assays. However, as we previously mentioned, in the context of HPV testing for cervical cancer screening, just getting increased analytical sensitivity will not be sufficient, and we are looking at other large, well-defined clinical studies to establish the clinical validity and sensitivity of it. So this is just a first study to show that you can indeed get great sensitivity. But of course, the clinical validity and sensitivity has yet to be, with clinical cutoffs, may change this a little bit.
Right. So there's HPV there, but what does it all mean, I think, is what we need to figure out. Yeah.
Right. Exactly.
Yeah. I think it was quite interesting. Initially I was thinking, well, why were we using urine for HPV? It's kind of like two different areas. But your studies, your data definitely show higher sensitivity, which kind of leads me to my next question, Jeff, which is how do the results that you guys saw in your study compared to other studies that have used urine for HPV screening purposes?
Yeah, so we're certainly not the first one to have studied urine for HPV screening. From a clinical perspective, the large volume and the variable composition of urine specimens, particularly as you mentioned, compared with the targeted collection of cervical cells, has contributed to variable performance in identifying HPV infections associated with precancerous lesions. We just published in December 2025 in another journal. I won't say sexually transmitted diseases journal, but another journal.
We don't talk about the other journals on this show, Jeff.
I know. I don't know how I got that in there,
it's
but
not worth reading.
right.
That will be edited out. Continue.
Right. So we reviewed much of the published literature on urine-based HPV testing. We found a very, wide range of sensitivity for detecting CIN 2+ lesions, ranging from 45% to 99% when compared, with standard care methods. So, HPV testing on liquid-based cytology traditionally been more consistent and reproducible with sensitivities in the high 80s to low 90s. So our recent efforts have been really focused on improving and standardizing the urine sampling through unique collection devices and technologies such as the Phasify, with the goal of bringing demonstrably consistent urine-based testing product into clinical practice.
Yeah, that's awesome. So you guys did some additional studies, and I think this was all, again, with that eye towards what's required for a CLIA validation of a lab-developed test. So you took a look at limit of detection as well as some analytic specificity. So Jeff, do you want to kind of take us through that, what you found from both that LOD and specificity side?
Sure. So the limited detection studies were conducted, following, as you mentioned, the CLSI guidelines by spiking each of the 3 HPV plasmids into negative urine in a series of 6 dilutions with 1 concentration above the LOD and one below that we had from previous experiments. And then each dilution series for each plasmid was spiked in and extracted with 3 separate lots of DNA extraction kits, and the DNA was tested in 12 replicates. So, a very robust kind of LOD study. And then the data for all 12 replicates in the series for each DNA kit lot were subjected to what's called a probit analysis, and the C95 concentration for each extraction of the 3 plasmids. We found the LOD to be between 15 and 30 copies per ml. Yeah. And then with respect to other HPV assays on the market, and remember, there's urine-based assays, which we talked a little bit about the variability, and then there's the, currently in clinical practice HPV assays, which, as Sharmila mentioned, have been tweaked, right, to maximize sensitivity and specificity. So I call it detuned. So the Roche Cobas actually has an LOD of anywhere from 150 to 600 copies per ml, which is higher than the LOD we found, but we need to do more work, to maximize that sensitivity and specificity, because as you said, just finding any HPV DNA may not be the right approach, right? We need to find a certain minimal or sufficient amount that has clinical relevance.
Yeah, definitely.
Makes sense.
And then did you see specificity issues? I mean, it's always kind of like this balance between sensitivity and specificity. So were you seeing any, spurious reactions?
I'll let Sharmila chime in on that in the
Sharmila,
lab.
Yeah, so no, I mean, from the LODs, because they were spike-ins into negative urine, we didn't really have any. So it was either detected or not detected in a dilution series. We didn't have any non-specific results from it.
Yeah. So one of the limitations for some of the current self-collect FDA-approved tests are, no product use, I think you mentioned menstruation was kind of excluded. So you guys didn't see any issues with products?
No, not with products. We did do an interfering substances study that we did mention that we did in this, and is reported in the paper. But with commonly used products, feminine hygiene products, we did not see any effect on the ability to detect low levels of HPV.
Yeah, that's a definite benefit. So, Jeff, your findings, clearly show that testing high volumes of urine can be a potentially beneficial alternative, non-invasive method for HPV screening. But can you share some of the limitations of the study as it currently stands?
Yeah, one quick point. I wouldn't call this necessarily high volume, right? So 40 mLs is kind of a standard collect that you probably get in the laboratory. So we're not, getting excessive amount of volume. It's not a 24-hour urine collection that is being, whittled down to the 60 microliters. But in terms of the question, I mean, a key limitation of the study was that there wasn't a rigorous comparison to histologically confirmed CIN2 plus lesions, and for FDA approval, one would expect that there have to be a clinical endpoint or a clinical comparator. So that clinical performance endpoint was beyond the scope of the study and what was not assessed, but that will be part of future studies.
Got it. Makes sense.
Yeah, definitely. So I guess, I think that's one next step, right? I'm curious, you've done a full CLIA validation. Are you using this test in studies then going up next? I mean, Sharmila, maybe you can tell us a bit about what's next.
Sure. Yes. So we do have we have initiated some studies already in larger populations.
Yeah.
One that was published recently in the International Journal of Infectious Disease. This was conducted outside the U.S. in China. Mm-hmm. And at Peking University, and the study was in a referral colposcopy population, so somewhat of an enriched population. And we have a second study in about 17,000 women, again in a study in China, which is in a screening population to answer some of these and more refine the clinical cutoff for risk for CIN2 plus disease.
17,000. That's a good number.
I was going to say, just a small study.
Yeah.
So beyond, HPV, we are also doing some other ongoing research to use this technology and implement Phasify technology for the detection of other biomarkers and analytes in urine, other STIs, other oncology-based biomarkers in urine. There is large scope for that, methylation markers. So there's a good number of studies being undertaken for that. Beyond urine, we're also looking at implementing Phasify in other sample types, specifically plasma, and that could have broader implications for in oncology in general. and other diseases and other diseases, neurological or otherwise. Yeah.
Mm-hmm.
Great.
Yeah. Well, thank you. I think that upfront concentration, if you will, technology is definitely promising. So thank you both for joining us. I think this was really, really informative. The self-collection of a swab was a big step, but now if we can move to no swabs and just urine, that would be even better. So thank you, Sharmila, for joining us.
Mm-hmm.
Thank you so much for having me.
Yeah.
It was a pleasure.
And thanks.
Yeah, no, I mean, I really think, urine, I mean, it allows also what we call opportunistic screening, right? So if people don't necessarily intend to get screened, perhaps, or someone forgets to be screened, it can be added on readily as a test. And also, there can be standing orders. There are different ways clinically from a population health perspective that urine just makes screening a lot easier and more routine, and ultimately brings more screening to women.
Oh, totally. One thing we didn't talk about is, all of these studies were done with urine collected in the clinical setting, right? So is the next step to kind of think about home collection and getting all of those verifications? And I'm assuming, I guess that would be another next step.
Yeah, so shipping studies, right? Temperature flex studies, and things to show that home urine collection. There's already, as you know, a big internet-based market on home specimen collection, shipping, and testing.
Yes,
for better, for worse. So this could potentially be a tool that could be used in that setting as well.
Yeah, definitely. You buy your toothbrush and your HPV screening test on the internet to get home delivered. It's coming next.
Yes.
I will say that would make it easier for me personally to keep up with my health matrix.
Romney, I'm getting worried.
Okay.
Well, thank you again, both. Really informative, really exciting stuff. So we appreciate you guys joining us today.
Very cool.
Romney,
thank you for highlighting this in the ways you've been highlighting it. Really appreciate it.
Really appreciate the opportunity. Thank you so much.
Yeah, it was really cool to learn about. Thanks, guys.
All right.
Thank you.
Bye-bye.
Romney, we'll see you next time.
Indeed, we will.
And for all of our listeners, if you've enjoyed, please again subscribe and rate. And thank you.
Thanks all.
Thank you.